the field is clearly evolving. It all started more than a decade ago now with the first clinical trials very early on were mostly based on preclinical work that was focusing on a mixed cell population that was derived from bone marrow in small animals, in larger animals, and that was then translated into the early clinical trials. It soon became clear that those cells were not really the best cell type to regenerate cardiac muscle cells. But it was quite clear that they had important paracrine effects. And so the trials were focusing primarily on patients with acute myocardial infarctions, initially with the hope that one could regenerate cardiac myocytes. That soon proved not to be the case. But the question came, how important is the paracrine effect? Can you modulate the healing and the repair response in the heart by taking advantage of paracrine actions that are associated with these cells? And we know that they release a lot of interesting molecules, growth factors, and mediators that could benefit the repair process and the healing of an infarcted heart. So that was the very early wave of small pilot phase trials that were focusing on acute myocardial infarction patients. The important issue to keep in the back of our head is always that the parallel with the development of advanced therapies based on cells and cell-based products was the enormous evolution in technology in cardiology. And the way we treat patients and the efficacy of our interventions and the better drugs, the better technology in the cath lab allowed at the same time for a much better outcome in STEMI patients that all had to do with very efficient, timely reperfusion therapy that was initially not as well developed in all countries as it is today. So the challenges against which the cell-based interventions were up to were changing quite significantly, I would say. The mortality in STEMI came down over the past decade significantly, so that more and more it became clear that we should focus to those patients, select out of the large population of STEMI patients, those that are at really increased risk of an adverse outcome. And those, as we know it now, are not all comers, but is about 15% of the population of STEMI patients that would really benefit from improved therapies. So that is important because in the selection of patients that you would treat, you need to really target those with an unmet clinical need. And that is an important lesson we learned. If you know that cardiomyogenesis is not really a realistic options with mononuclear cell as they are isolated from the bone marrow. The question is there a way to regenerate cardiac muscle? And that is then the second wave of interventions where progenitor cells that were derived and isolated from within the heart. And we know that in the human heart, there are some progenitor cells. And the idea was, can we use better is it a better option to use those cells rather than bone marrow cells? Are they more committed towards regenerating cardiac muscle? That was the second wave. And also there, it became clear that in preclinical and clinical testing that there is indeed some capacity to make new cardiac muscle cells, but insufficient to really mediate a clinical effect. So then I think that the future for really repairing a very advanced stage of heart failure and providing new muscle mass and perfusion of that muscle mass at the same time would be to take advantage of what is now the latest development, the generation of cardiac myocytes from induced pluripotent stem cells, which is not only an advantage or an alternative to the embryonic stem cell derived cardiac myocyte population, but the option to generate these cardiac muscle cells from induced pluripotent stem cells. So that is a little bit the way we see the field evolve, and where we should focus in the future.